gets to another really interesting phenomenon, is that for all of these drugs, it seems that there seems to be more activity in pancreatic neuroendocrine tumors than carcinoid tumors. James, that seems to be holding true for the targeted agents as well, or?
It certainly looks like that way in the currently used targeted agents. The phase 3 trials are showing differences in the level of benefit. For example, in the RADIANT-3 study of everolimus in pancreatic NET, the hazard ratio was 0.35, implying a 65% reduction in the risk of disease progression. In RADIANT-2, which is in the carcinoid population, the hazard ratio is like 0.77, which means that magnitude of risk reduction is far less, and the study didn't really achieve statistical significance. But we're going to look at that in a separate study, RADIANT-4, to see definitively one way or another whether it's going to have a role in non-pancreatic NETs.
It gets to then perhaps a big and wide open question is where might you see things headed? We've clearly had some pretty major successes in pancreatic neuroendocrine tumors, a lot of work to do in carcinoid tumors perhaps with some upcoming studies. Are we going to be looking at combinations? Do we need new chemotherapies? Where do you see clinical trials going over the next few years?
Well, that's a very excellent question. I think the answer is going to slightly differentiate based on whether, which disease subtype we're looking at. I think that the big division we have right now is between, carcinoids and pancreatic NET. I think as we go forward, we may be further subdividing the carcinoid cohort. We're not dividing them right now because there really isn't any difference in the way we manage the tumor. We already know that on molecular genetic level there are differences between a lung carcinoid and a small bowel carcinoid and so forth. I think there could be further differentiation in future trials. I think the first changes likely to come are really based on trials that are already underway and may have already completed accrual. And there are at least 2 phase 3 trials that have completed accrual, and one of them is the clarinet study that looks at lanreotide versus placebo in patients with non-functional neuroendocrine tumors. So similar to the PROMET data, but expanding on other primary sites. And the other is the SWOG 051A study, which essentially compares octreotide plus interferon versus octreotide plus another VEGF inhibitor, bevacizumab. And I think you're a PI on a study that's going to look at some new agents in pancreatic neuroendocrine tumors as well.
There are several new agents on the horizon. Hopefully some of them will work. It does get to another question, though, and something that seems to be really evolving over the past few years. If we go back even 5 years ago, there were literally no treatments for these patients, or certainly no approved treatments for neuroendocrine tumor patients. So patients were getting referred into referral centers, and virtually all of them were going on clinical trials. And in fact, these trials have enrolled very, very rapidly.